our intervention that I'll be talking to you more about, but its overall objective is to support PrEP adherence. Please, at any time, if you have a question, feel free to unmute yourself and ask. No need to wait till the end of the presentation today. Right. So I wanted to provide a little bit of context about the intervention itself. So for those of you who I'm not familiar with, I have been at UC San Diego since 2011 when I joined UC San Diego as a doctoral student in the clinical psychology program. And since then, I've been working with David Moore, who's developed the ITAB, which is the Individualized Texting for Adherence Building Intervention. Now, this intervention involves daily interactive text messages that are intended to support medication adherence. And so I want to bring your attention to the right side of the screen where you'll see a screenshot of an ITAB text message string. So the ITAB system sent a text that read, "You can have fun and take your meds. Take your small white pill now. Reply A, took, D, didn't, G, snooze." And for this recipient, they indicate that they took their medication by responding with an A, and then they received a positive reinforcement text message. In this very old iteration of ITAB, they were given additional information about their adherence rate and what their adherence rate would look at if they were to take their next dose. So one of the things I want to emphasize here as being unique to this intervention is that these messages are sent at someone's preferred dosing time, meaning if they indicate that they take their antiretroviral therapy for HIV at 7 a.m. every day, that's when, around that time is when they would receive an ITAB message. And it allows for a lot of personalization. So here you see in the message, it says, "You can have fun and take your meds," which is broadly categorized as a health promotion message, but they can also choose factoids so that every day they're not receiving the same exact message. Rather, there's variety in the types of messages that people are receiving so that we avoid the process of habituation. And then there are built-in features to the ITAB system, where if a recipient does not respond for 3 consecutive days, they are sent a follow-up text to really prompt reasons for non-responses. And then after 5 non-responses, the ITAB system alerts a research coordinator to give the participant a phone call. So the ITAB system is mostly geared towards supporting adherence, but has also been used to help assess for mood, particularly among people with bipolar disorder, as well as to assess for methamphetamine use. So when I joined as a doctoral student, we were wrapping up some of the initial studies of ITAB. And we've referred to one of those initial studies as ITAB-M, which was essentially recruiting people who actively use methamphetamine who had HIV. But along the way and over the years, we've also have iterated ITAB to be tailored specifically for PrEP adherence. So one of those studies is what we refer to as the TAPER study, which was a CCTG trial of ITAB to support PrEP adherence. You'll notice that the flavor of the messages changed at this point in time, where they involved some random facts. And this was based on focus group interviews where people on PrEP really did indicate that they wanted the messages to be entertaining and not so much around any sort of health behavior or health prevention. And then in our most recent iterations of ITAB, we've tailored the intervention to specific racial ethnic groups. So in one iteration, we have what we refer to as IC Change Study, which was conducted with the Family Health Center of San Diego, where we really aim to support antiretroviral therapy adherence among African Americans living with HIV. And so a lot of the messaging there pulled from different historical events relating to African American achievements as well as culture. So that was a lot of the work that I did throughout my doctoral studies and as a postdoc. And around the time where I transitioned to becoming faculty, the Ending the HIV Epidemic initiative was announced. And I believe it was announced back in 2019 with the explicit goal to reduce new HIV infections in the United States by 75% by 2025 and by 90% by 2030. So quite ambitious goals, but there was a four-part steps to this, which is one, diagnose all people with HIV as early as possible after infection, preventing new HIV transmissions by using interventions like PrEP, treating effectively those who have HIV and sustaining viral suppression, and then responding as quickly as possible to potential HIV outbreaks. And so in my current work, I really have highlighted that a lot of the behavioral interventions that I've been involved with tailoring over the years are really geared towards supporting EHE goals. And so thinking about ITAB and using it to support PrEP adherence, it really does address the pillar of prevent, which is how do we get people on PrEP? And then once they're on PrEP, how do we sustain and support their use of PrEP? So for this current study that I'll be sharing with you today, we do indeed address the EHE pillar of prevent. And prior work has demonstrated that to really reach maximal public health benefits of PrEP, daily adherence to PrEP is ideal, but really the target that we most care about is achieving at least adequate adherence, which oftentimes is referred to as at least 4 doses of PrEP taken per week. And this is based on a daily dosing regimen. And for this project, our innovation was the ITAB system. It's a CDC evidence-based intervention that has shown efficacy for supporting PrEP medication adherence and persistence. And as I mentioned in previous slides, it's a 2-way daily interactive text messaging system that affords flexibility in shaping the personalized reminders to match a patient's preferences, and they can be sent on a personalized dosing time schedule. So the project that I'm presenting today is a community academic partnership that exists between UC San Diego and the Los Angeles LGBT Center. So David Moore and myself were the co-project directors. And then we had a team at LA LGBT that really were essential to success that we've had so far. So to give you a little context to the patients at LA LGBT who are taking PrEP, they in the year 2019 through 2020 had approximately 2,500 people who were prescribed PrEP. Majority were whites. However, what you'll notice is a sizable portion of Hispanic Latino males, as well as a significant portion of people who identify as Asian, Pacific Islander, Black, African American, or more than one race. So this is one of the reasons why we elected to work with the LA LGBT Center, is just kind of the sheer volume and reach that we could potentially have at this large center. So for those familiar with EHE work, there is a call to incorporate implementation science frameworks in the work that we do. With the goal really is to understand the processes for how interventions get adopted and how they get implemented effectively. So the idea really is that the work that we're doing at LA LGBT, trying to understand what are the universal features of our implementation work and how could they potentially generalize to other centers or healthcare systems supporting people taking PrEP. So this is the Exploration, Preparation, Implementation, Sustainment Framework. Shorthand, it's referred to as EPIS. That was developed by Dr. Greg Ahrens in the Department of Psychiatry at UCSD and his colleagues. And what you'll see in this figure is that the implementation process is recognized to contain 4 different phases, which are referred to as the exploration phase, the preparation phase, implementation, and sustainment. They're depicted as a circular process because it's recognized that implementation efforts are not always linear, meaning that you could have prepared to implement something, but then you see that there's a leadership change or change in priorities or even funding that sets you back, and you're now in the exploration phase of figuring out how to attend to the new urgent health priority. Or you may be in implementation phase and realize that people are not adopting your evidence-based innovation. And so you have to go back to preparation to really understand the barriers that are getting in the way of effective adoption and implementation. So for this current study, we are where we would say in the exploration and preparation phases, where we're exploring what are the health needs in regard to those taking PrEP, and how do we prepare the LA LGBT staff and providers to be able to refer patients to ITAB and get them connected to that system. We in our project also assess for different factors, the inner context factors, which refer to things like implementation climate, availability of workforce or leadership support. But we also wanted to understand innovation factors such as, is ITAB able to be integrated in the center? Is it acceptable? Is it feasible? Is it something that's appealing to their providers? Is it something that's appealing to their patient population? And acknowledging that this is all taking place within the outer context, meaning that LA-LGBT is well aware of the Ending the HIV Epidemic initiative and has competing research demands on them. And given the COVID-19 pandemic, that's also shifted patient behaviors and needs. But all of this was understood by our community academic partnership and received a great deal of support from our own C4 Ending the HIV Epidemic Scientific Working Group. So we had 2 primary aims for our study. The first being to evaluate the perceived acceptability, appropriateness, and feasibility of ITAB to support PrEP adherence among LA LGBT clients. And our hypothesis was that ITAB would be rated as highly acceptable, appropriate, and feasible. And then in our second aim, we wanted to define the determinants of implementation and sustainment of ITAB at the center. And we hypothesized specifically that the inner context factors, such as the availability of the center's workforce and workflow disruptions, would be identified as barriers to implementation and sustainment. So we had 2 different participant types here in this study. One was the clients and one was the personnel. In terms of inclusion for the clients, we kept that relatively broad. They had to be HIV uninfected and older than 18 years of age. They either had to have a current or past prescription of PrEP and receiving services through the LA LGBT Center and able to provide informed consents. And really the only exclusion criteria was being unwilling to provide consent or share their experiences taking PrEP. For personnel, it was even more broad. They had to be 18 years of age or older and then serve in either a leadership position at the center, a physician or physician's assistant, social worker, case manager or nurse at the center, or be a center staff who was involved or knowledgeable in the clinical care of individuals taking PrEP. They also had to be willing to provide informed consent. So we used a mixed methods approach that consisted of qualitative interviews and quantitative surveys. For the clients, we were primarily interested in asking them about their experiences taking PrEP, what supports they currently have to keep taking PrEP. And this was explicit to their adherence and their persistence or non-persistence in taking PrEP. For personnel, we wanted to know what strategies or services their team discussed with clients to help support PrEP adherence. And we also wanted to understand the center's process for adopting new practices like ITAB. During the qualitative interviews, we also provided a presentation of ITAB to orient the participant to what exactly the intervention consisted of, and then to receive their feedback on what features of ITAB appealed to them, what they would change to make it more appealing. And then we also had some implementation specific questions, such as if ITAB was available, how would you want it to be set up with a provider, or would you want to be able to set it up by yourself? And then if ITAB was offered at the LA LGBT Center, would you want your adherence data shared with your providers? For the quantitative surveys, for both providers and clients, we collected demographic information. And then clients specifically, we asked about PrEP use and eligibility. So what indicated their use of PrEP. We asked about their PrEP adherence as well as their cell phone usage, given that this is an intervention delivered via cell phone. For personnel, we administered several measures related to implementation. So a group innovation inventory, an implementation climate scale, an organizational climate measure, and an organizational readiness for change. And then for both clients and personnel, we were interested in acceptability, appropriateness, and feasibility. So during the study, we had the wonderful opportunity to engage with the San Diego CFAR Implementation Science Hub. And as a result of that hub being funded, we were afforded the opportunity to engage in monthly implementation science coaching / consultation sessions. So we were assigned 3 coaches, Dr. Gregory Ahrens, Katie Wilging, and Miley Karras, who were really meant to provide guidance to the different methods that we were using, as well as to just help problem solve any barriers that we encountered and to plan for subsequent grant applications. So we started meeting with them on a monthly basis beginning in December 2020. And as a result of those coaching sessions, our coaches recommended that our group participate in monthly periodic reflections. So those new to the implementation science world, periodic reflections essentially are a time where their research team gets together, and similar to a quantitative or qualitative interview, you have a standardized interview script that you're using with your research team to reflect on your group process. So what the current progress you've made as a team has been, what challenges you're encountering, and how you've problem solved around those challenges, and then what the next steps are. You want to record these periodic reflections because they essentially become a form of qualitative data to analyze. And the idea being understanding team science. How is the team working effectively or ineffectively, and how are decisions being made? So we initiated those sessions in April 2021. And then we also had the opportunity to participate in a virtual peer feedback session that was organized by the ISKI. And the ISKI is the National CFAR Implementation Science Hub. And we were given the opportunity to provide feedback among a group of other EHE projects that were working on implementing communication strategies for prevention with young MSM. So these were other groups that were also focused on the pillar of prevents through PrEP, and then focused specifically on innovations where communication was the primary strategy. And so this offered us an opportunity to share our work with ITAB and also the challenges of bringing an intervention that was developed in academia, and how do you scale that outside of academia? So I'll be talking a little bit more about that. For our data, we applied a rapid qualitative analysis, which has been developed by Dr. Ellison Hamilton of UCLA. And this approach is much quicker than more traditional deductive approaches to qualitative analysis. In this approach, you develop a summary template with a priori domains that are really drawn from your interview guide. And I should highlight that our interview guide was really based on the EPIS framework. So within these a priori domains are already some theoretical constructs that we were interested in understanding. We then had 3 team members use this template to summarize each of the transcripts. So these transcripts, would range from 15 pages to 35 pages. And the idea behind these summaries is that you condense all the key important information relevant to your domains into a 1 to 2 page document. And then from these summaries, you develop a matrix where you put the information in table form. Essentially, or every column represents a priori domain, and every row represents a different participant. And that allows you to really succinctly and precisely see the variation in responses to the different interview prompts. And given that we didn't necessarily have a comparison condition for analysis for the quantitative data, we simply are providing descriptive statistics at this point in time. So we met our recruitment targets, which was to interview 25 clients of the LA LGBT Center, and then to interview 10 providers, staff, and leaders of the center. So here I'm presenting only data on 8 of them. The 3 others, by the time we pulled this data, had yet to fill out the survey data. So I don't yet have the demographic information for the 3 remaining leaders. But what you see here is that on average, the clients were about 31 years of age, with some variation of about 9 years. And then the personnel at the LA LGBT were slightly older, with a mean age of 37. Majority identified as being male. We had a handful who identified as being trans male or trans female or genderqueer. And then I present the race ethnicity data. We did a great job recruiting Hispanic Latinx and Black African Americans. And then you see here among the personnel, majority also identified as Hispanic Latinx. So now I'll be presenting the qualitative data. So in regard to participant responses about PrEP adherence, we found that the majority of clients reported strong PrEP adherence with very low reports of occasional forgetfulness. And that really ranged from forgetting to take PrEP 1 or 2 times a month to maybe forgetting to take PrEP 1 or 2 times a year. So I do want to really highlight this because I do think that recruiting a participant group that was highly adherent did impact responses to our other questions. But the most common reason participants reported missing occasionally was that they had a change in their daily routine or they were traveling. And so that interfered with their ability to stay true to their dosing schedule. And the second most common reason for non-adherence to PrEP was issues related to prescription refills. And this was often in the form of not realizing that their PrEP, that they were almost done with their current prescription and therefore needed to request a refill, and there being a delay of when that refill got filled, and then obviously then obtaining the pills themselves. In terms of how the supports that patients had in place to support their PrEP adherence. Many reported that they had at least 2 forms of supports, with primarily the first form of support being social support and at least one other strategy. And so on the right-hand side here, you'll see the most commonly endorsed types of support strategies. So social support, again, was number 1. But we also saw a great number of people seeing that they do use a calendar or a phone alarm to alert them to take their PrEP. Some people use a mobile app or have even used ITAB through a RCT that has been conducted at the LA LGBT Center. About 6 people reported using a pillbox, and then 7 indicated another behavioral strategy, such as matching PrEP taking with another behavior, say brushing your teeth. And those who missed taking their PrEP said more frequently than just occasional, really didn't seem to benefit from any of these adherence supports. So these are really most highly endorsed by those who report strong adherence. Now, this is some data from our providers and staffs related to their current practices for supporting PrEP adherence. So in terms of what the center currently offers to support PrEP adherence, the responses from participants really did range. Some saying they had an abundance in terms of strategies that they offered to their patients, and others saying we don't have anything. And those who said that they had strong support for supporting patients' PrEP adherence said that they did so at every meeting or encounter with patients, and that they thought that having additional training for staff and providers on the importance of adherence might better support patients with their adherence. In terms of barriers for supporting patients' adherence to PrEP, many of the providers pointed to there being a lack of outreach services, especially for trans women and other sexual gender minorities. And again, what people really pointed to as making the biggest impact in terms of supporting people's adherence was having a designated staff member who was responsible for talking with patients about their adherence. And then in terms of how effective they thought these strategies were, we also received a wide range of responses, some saying that these strategies really were not that helpful, and therefore they observe low adherence to PrEP among their patients, and others saying that these strategies are quite helpful and that their patients have high adherence. They tended to think that adherence supports were more effective when they were free and accessible, and also thought adherence supports were ineffective for patients specifically who had unstable housing. But there was a lot of talk about how a strategy is only so effective in the sense that it helps bridge a connection between a client and provider, or in the other opposite direction, that a strategy was effective because there was already an individual relationship between the client and the provider. So here's some of our quantitative data related to ITAB's acceptability, appropriateness, and feasibility. So in the green bars, you see our averages among the clients, and in the blue bars, you see our responses from providers, staff, and leaders. And so for this particular scale, it's a Likert scale from 1 to 5, and 3 is a neutral rating. And as you go to higher ratings, it indicates greater acceptability, appropriateness, and feasibility. So in general, we had high ratings. You'll see here the appropriateness was a little bit lower for the clients. And I really do think that that had a lot to do with the perceived fit for many of the clients who were already endorsing very high adherence to PrEP. So many of them felt like they were already doing a great job being adherent. They already have strategies in place, and ITAB seemed like overkill. I don't anticipate that the appropriateness ratings would necessarily be the same if we had recruited participants who reported lower adherence to PrEP. As I mentioned before, part of our data collection also involved gathering information about ITAB's specific appeal and any recommended adaptations that we would need to make to ITAB to make it more ready for implementation at the LA LGBT Center. So for among clients, they've really found that the customization of the message themes and the ability to name the pill or to disclose it in some sort of way or not disclose it in some sort of way were very appealing features to the system. They appreciated that the messages were interactive, and they also liked the idea of being able to see a calendar view of their PrEP adherence that was based on their responses to the ITAB system. The providers were also very strong in their interest in implementing ITAB. They also saw the customization of ITAB as being an appealing feature. They liked that it was discreet and that showing patients a calendar of their PrEP adherence they thought might help reduce stigma around using PrEP as well as being adherent to PrEP. Their disadvantages were that potentially receiving daily reminders to support PrEP adherence would result in client fatigue. And then the clients, in terms of their recommended adaptations to ITAB, suggested that we add reminders to prompt them to request a prescription refill and reminders to alert them to their upcoming appointments at the center. They wanted more customization as it relates to the calendar of their ITAB responses. Some, and I would say this is probably split, but about half indicated that they wish that ITAB was a mobile app. And some indicated that they wanted ITAB to remain a text messaging system. A lot of that feedback had to do with whether or not the degree to how much a patient recognized if they would be responsive to notifications from an app versus a text message. And I think that there was variability where some people indicated, I'm really good at ignoring notifications to an app. So that wouldn't work for me. And others saying, I really like the customization that mobile apps afford. So I'm willing to forego, kind of the downfall of having notifications. And then clients also recommended that we streamline the setup process to make it easy and more customizable, but at the same time, an easy to understand process. And then in terms of the providers and staff, they suggested that we incorporate non-PrEP related prompts to the text messages. So assessing for things like changes in mental health. They also recommended that the ITAB data be directly integrated into the medical charts, and that they wanted ITAB to be able to generate reports of patients' adherence to the ITAB message. And they wanted this both graphically, such as in a calendar, but also to just have a summary statement saying, in the past 30 days, this patient has been adherent to PrEP at 87% or 100%. And given that this was an implementation science study, we were interested in understanding some implementation considerations such as setup and data sharing. So clients were pretty split between whether they wanted ITAB set up on their own or with a provider. Some patients just said, you know what, I could do it quicker. I'm very good with technology. Let me go at it. And others saying, I might mess up some of the features or not understand all the features. So it'd be great to have a provider be able to walk me through that process. And then with the providers, there really was more of a consensus that providers, staff, or even IT should be involved and the setup of ITAB with patients. And then in regard to data sharing, clients in general approve sharing of their adherence data with providers and believe that sharing that data would help improve their adherence and add additional accountability. But I would say they also indicated that they wanted to consent to having that data shared. So it not being necessarily a full option, but something they consent to having shared. And then providers and staff also wanted that data to be shared. And again, this makes note that they wanted either a visual representation or a numeric value indicating a patient's PrEP adherence. And then specific to providers and staff, we asked about the center's capacity to be able to implement ITAB at their center. We had 2 respondents saying that the center had clear capacity to do so, 2 saying that the center had no capacity, and then 4 individuals saying they were uncertain if the center had capacity or not. And so some mediating factors impacting capacity, of course, was COVID-19 and the amount of resources and availability being limited due to the pandemic itself. But also a facilitator potentially of implementing ITAB was that there's been a shift toward offering more and more telehealth services. So this potentially could be in line with that. Barriers to implementation included the time demand for having to train providers and staff for using the technology. Another could potentially be language barriers. So I should have noted that ITAB is currently available in both English and Spanish, but that's still limited in the sense that there are other languages that are left out. And then obviously a big piece is always funding, which is that the ITAB isn't free and funding is always concerned. So if a new technology is being implemented at a center, what funds are used to cover the costs? And then facilitators of the implementation were that there's clear efficacy of ITAB. It's recognized as a CDC based intervention approach for supporting PrEP adherence. And that currently there was some increased funding to support such technology. Facilitators would be that with this community and academic partnership, we would be able to assist in the training of providers, clients, and IT. That ITAB does fit within their current initiatives within the PrEP clinic. And so that was in line with their current ongoing activities. And that they really thought that ITAB could be promoted internally and externally. So in summary of what we learned for our mixed methods approach was that the patients we recruited for the study had high adherence, and that tended to be mediated by routine disruptions as a barrier, and it's also mediated by social support as a facilitator. Current practices from the center in terms of supporting PrEP adherence were largely reliant on established connections between patients and providers. ITAB as an intervention to support PrEP adherence was appealing because it is customizable. It does allow patients and providers to see adherence data, and overall has very affirming messages. There was some split between patients and providers about how it should be set up, as well as some kind of general consensus that this data should be shared to build accountability, and that visual representations of ITAB data would be ideal. In terms of needed adaptations to ITAB to support its future implementation, there was suggestions to increase its customization, potentially make it an app, increase the different types of reminders that ITAB offers, such as reminding for prescription refills, as well as appointment reminders. There was a desire for it to be integrated directly into the patient chart and for it to be able to generate shared reports. some implementation considerations. We're still going through COVID-19, so the capacity to take on new initiatives has changed during this time. And then we also need to additionally consider accessibility and any technology barriers that some patients at the LA LGBT Center may encounter. So for our current research activities, we're working on adapting ITAB based on the recommendations we received for future implementation. We have also developed an implementation research logic model as part of this grant application. And based on our emergent data, we'll be updating that to really refine a implementation strategy to support implementation and sustainment. We are continuing to analyze and interpret the data. So we still have a great deal of quantitative data that has yet to be analyzed. And then as we move forward, we'll be disseminating our findings, the first being an oral presentation at the annual conference on the science of dissemination and implementation in health. And we've had some submitted abstracts to the Society of Behavioral Medicine. And I believe our next grant idea is to really support a multi-site implementation of ITAB across different sites serving patients taking PrEP. So I want to acknowledge my co-project lead, David Moore, our co-I, as well as our research team at the LA LGBT Center. Our implementation science coaches have really been phenomenal in helping with the rigor of our implementation science approaches. And then we have a great deal of UCSD staff, our data team and trainees who really make this work possible. And then I want to acknowledge that this work was funded through a CFAR ending the HIV epidemic supplement. All right, so with that, I will wrap up and ask if there's any questions. Nice to see you, Daphna.
Great talk.
Thanks. Thank you, Sarah. Good to see you too via chat. Okay, well, Kim, if there aren't any questions, I don't know if you have any wrap up that you need to do.
I'm all good. Thank you so much for your presentation today. It was awesome.
Thanks.